Hello, I'm Dr. Maury Markman from City of Hope, and I'd like to continue the conversation we started last session on Minutes with Markman, where I discussed the frequent inadequacy of the reporting of the full extent of toxicity associated with antineoplastic therapeutics in the peer-reviewed publications, as well as very common and unfortunate overstatements in general conclusions related to the tolerability of regimens. In this session, I want to turn the conversation to a different aspect of the question of antineoplastic drug toxicity to really highlight the change in the oncologist drug-based armamentarium over the last several decades, and then to emphasize simply the difficulty today of using our current toxicity criteria to evaluate side effects based on this change. Unfortunately, the criteria which we use, which is excellent, it's been incredibly helpful, common language, it may simply not be adequate for the treatment paradigm today. For example, in the past, not that long ago, standard treatments with cytotoxic chemotherapy were short courses, generally 4 to 6 cycles, given systemically every 3 to 4 weeks. Didn't matter what the drug was, that's how we gave them. Rarely use oral therapies, often because patients had nausea, threw it up, didn't want to take it, and if we gave it IV, well, at least got it. The drug certainly was the case for cyclophosphamide. And why do we give the therapy only 4 to 6 cycles? Well, often because it was all you could take, the patient could tolerate from it because of the side effects, but also therapy wasn't that effective. Certainly in the metastatic disease setting, 4 to 6 cycles, maybe what you saw, maybe it was less in terms of effectiveness. And then when we went to second line treatments, the therapy was generally even less effective. We gave it for a shorter period of time. Of great importance, the major side effects seen in these agents at that time, even today when we use these drugs, were hematologic side effects. They could be very serious, but it was hematologic, platelets, white count, obviously red cells, nausea and vomiting, and more serious, fortunately less common, kidney, cardiac, pulmonary, even hepatic side effects. Of course, there was always fatigue now and then. So I put that on a side because that was obviously side effect that was relevant no matter what we give our patients. The point I want to make is that these effects, hematologic, renal, cardiac, pulmonary, hepatic, were relatively easy to objectively measure with blood tests. Even nausea and vomiting could be relatively objectively evaluated because you couldn't do that with the nausea, but go with the vomiting. How many times did the patient throw up? How many times did the patient retch? How many days or how many hours did the side effect occur? You could objectively measure that. Cardiac, of course, we could use ejection fractions. Kidney function, of course, we could look at creatinine clearance or even serum creatinine, same thing with hepatic or pulmonary function tests. Contrast that to today. Oral treatments are common. Daily therapies are often common. Durations are dramatically prolonged, not necessarily 3 to 4 months, but perhaps 1 to 2+ years. Many cancers, and in many settings, are becoming much more chronic disease processes. Our second-line therapies, even third-line therapies, may be very effective. It can also be given for very prolonged periods of times. Again, greater than a year, even 2 years. The point to be made is these drugs have very different side effects in of themselves. How we give them much more frequently, meaning daily, sometimes even twice a day, is vastly different. And they may be given for a much more prolonged period of time. And what about the impact on what the patients experience, the side effects? That we will cover in the next session. And I thank you for your attention.